PD brain. Okay, so Nader Pouratian, MD, PhD, is an associate professor of neurosurgery, radiation oncology, and bioengineering at UCLA, where he's also the director of neuromodulation, stereotactic radiosurgery, and peripheral nerve surgery programs. He specializes in surgeries to restore and preserve brain function, including DBS and other surgeries that require brain mapping. His research focuses on developing novel interventions and technologies for neurological restoration with a specific interest in the physiology of Parkinson's disease and motor control. He currently serves as a member of the executive committees of the Congress of Neurological Surgeons, as well as the American Society of Stereotactic and Functional Neurosurgery. So welcome, Dr. Pouratian, and I will turn control over to you.
Thank you very much for this opportunity. This is a great opportunity because, as you heard, I'm a functional neurosurgeon. I take care of patients with movement disorders and Parkinson's disease, but I'm also what we'd call a clinician scientist. So I am trying to not only help the patients that I'm directly helping in surgery, but trying to learn more about the brain, how Parkinson's disease affects the brain, and Parkinson's disease in general. And so in some ways, I take advantage of the unique opportunity I have to study the human brain, especially patients with Parkinson's disease, so we can advance our overall understanding and help even more people. So without much further ado, what I'll do is I will share my screen and my talk. I'm going to aim, as you might imagine, a lot of the stuff that I do does get very technical, and I'm going to try not to be too technical, and it might seem that I'm glossing over some details. And I apologize if you want more details, you can ask me for it afterwards, but I want to keep it at a level where we can all have a good conversation about the material that I'm sharing. Okay, let me just get rid of that. All right, so when we talk about patients with Parkinson's disease and learning from their brains, this all has to do with research. And in many ways, everything that we do is some kind of clinical trial. And I wanted to lay a little bit of groundwork about what I'm going to be talking to you about, because we're going to be talking about a few different areas. And patients with Parkinson's disease have been extremely generous with their time and themselves to advance our field. And there's, at the top here, we have, there are therapeutic clinical trials where people enroll in these trials so that they hope to get some kind of benefit. And I'm going to start with talking about what we've learned about deep brain stimulation from those types of trials. So there's, an individual benefit there, but there's two other types of research that we do that have also taught us a lot about the Parkinson's disease brain. So part of my research is to record signals directly from patients' brains without a direct intent to help the person that I'm recording from or who's participating in research, but with a mutual intent to really learn about Parkinson's disease itself. So these patients are being very generous of themselves because they don't expect anything to come out of it, but they want to help others who may be in their shoes in the future and help the entire group of people with Parkinson's disease and movement disorders. And finally, we actually do some studies as well, not even to focus on Parkinson's disease, but just to understand the human brain. And ultimately, our hope is the more we understand about the human brain, the more we will understand about Parkinson's disease, but also other diseases. And so that's this last group here where we do studies to understand human neuroscience. And there's no benefit to the individual. There's no benefit to their group either. So not directly benefiting Parkinson's disease, but a benefit to society. And so it's really altruism that drives this in our volunteers. And before I go much further, I want to thank them for that, because we make progress as a team. helping one another. I can't do what I do with my team here at UCLA, my team of researchers, without the patient volunteers. And likewise, I think patients and society needs us to do the things that we do. Everything presented here is going to be due to the really selfless contribution of patients who volunteer for research. And we really should acknowledge the role of government as well as private foundations in supporting this type of research. A lot of this work is funded by something you might have heard called the Brain Initiative, which was launched by President Obama several years ago, and is really putting a lot of money into understanding how the brain works. That's sponsored by the National Institutes of Health, DARPA, which is our defense agency's research arm, as well as the National Science Foundation. So without now going into some of the science, where I come from as a functional neurosurgeon is I want to restore function for patients. And I want to do that in order to improve quality of life. That is my overall goal, as well as other functional neurosurgeons who have similar practices to myself. And in doing that, we really have to develop patient-specific therapies. We need to understand what our patients need, what their symptoms are, and how we can use the tools that we have to address those symptoms. A little bit of background about how we got to where we are. Historically, restorative neurosurgery was a field of lesioning the brain. We had people like Walter Freeman, who actually wasn't a neurosurgeon, but popularized what we call psychosurgery, where he did an ice pick lobotomy to do a frontal lobotomy through the eye, basically. We had others like Irving Cooper, who was purposefully causing strokes in patients to treat Parkinson's disease. And the development of a tool that we use almost every day in neurosurgery, which is radiosurgery or focused radiation, was actually developed to try and target parts of the brain to help function. But all of these techniques, our history really comes from treatments that required damaging the brain. And we moved beyond that to our current practice of deep brain stimulation, saying that we don't need to damage the brain. Instead, what we could do is put an electrode in the brain, turn that electrode on, and jam circuits in the brain or change the function of the brain in order to make people better. The advantage of this is it's reversible. So, as opposed to a lesion in the brain, we can't undo a lesion, but stimulation we can turn off or on. But we can also increase stimulation. We can change the frequency. We can change many things. So deep brain stimulation gives us a lot of flexibility. And that's why we like it as a field. But it also gives us a lot of opportunity to understand and study the brain during the surgeries. And I'll get into that. So with deep brain stimulation, what we're trying to do is get electrodes into very specific spots in the brain, depending on the specific symptoms that a patient has, depending on their overall function, health, and other factors. In order to do that, I'm giving you this background because it's going to lead to the results that I'm going to talk to you about. We do surgeries where the patient is usually awake on the operating room table, which you can see here. That's me operating on this patient. We're putting electrodes very precisely into the brain. This right here is what we look at during the surgery. That's actually looking at individual cells or neurons that are firing in the brain. And this is your first glimpse into how we can use the operating room environment to study brain function. We take x-rays to make sure we're in the right spot, and then we test the patient during the surgery as well. In general, the most common practice is to do awake testing during surgery. And in this case, the patient brought a guitar to the operating room, but we do other tests as well, moving your finger back and forth, opening and closing your hand to test for rigidity, looking at patients' tremors, many, many different tests to make sure we're in the best spot possible. And this traditional way of doing surgery, the way that most centers do the surgery, really gives us another opportunity to study brain function as well, because if a patient's awake, we can take a little bit of time with their consent and do some additional studies to look at how the brain functions and changes with very specific tests. I do want to give a nod to asleep DBS surgery, and that's an entirely different discussion. I think there was a webinar on this earlier, but you can have MR guidance to place an electrode at a sleep state, or CT guidance. And those are very valid techniques. A lot of data coming out to support those techniques, not as much experience, and so not all centers have adopted it. But I really do think that the type of research that we are doing, that I'm going to talk to you a little bit about, is actually going to allow us to do these asleep procedures with much greater safety, precision, and confidence as well. So really, these techniques are complementary, with all of us moving in the same direction. You know, once we get the electrode in place, there's programming that needs to happen. That takes over, that occurs over several months, sometimes 3 to 6 months time, and it's very complicated, and again, beyond the scope of what we're going to talk about here. But I wanted to give you the whole picture of how we do these deep brain stimulation surgery, because the surgery is just one part, but turning the stimulator on and managing it is just as important, and I rely quite heavily on my partners in neurology to do that. I want to show you a clip of what we see with deep brain stimulation surgery. This is a patient who's given consent to have the video shared. This is a gentleman who has tremor dominant Parkinson's disease, and you can see he's got a resting tremor in that right hand. He will do certain movements. He hurt his shoulder right before this video, so he's not raising his right shoulder as much. And you can see that tremor still in that right arm. Now the tremor comes out on the left side as well. And a little bit of slowness with tapping of the fingers, as well as with opening and closing the hand. And we're going to turn the stimulator on in just a moment, and we'll see the effect of stimulation. And one thing you'll notice is that it's almost immediate, the benefits that we see, and that helps us and is important for the research that we do that you'll hear about. So he's moving a little bit better. You can see the tremor is essentially gone now with the stimulator on. And then he's able to tap his fingers at a faster pace on both sides, and he's able to open and close his hands faster as well. So a video is great, but that's only one patient, and we want to show you really what we've learned, as we said, from the, just in terms of outcomes. Most of the people that we implant, the #1 group of patients that we implant with Parkinson's disease are those with motor fluctuations. So you can see in this dotted line, people whose course is up and down throughout the day. And with stimulation, people still have ups and downs, but they're not as great and they're more controlled. And so the #1 patients we implant are those with motor fluctuations. That's the on-time dyskinesias, the wearing off of the medications, and also patients who just are intolerant of medications. So here's one glimpse of a clinical trial. So, clinical trials really require patients to give of themselves. They're entering into a trial where there is what we consider technically clinical equipoise, where we don't know for 100% that one treatment is better than the other. We all want to think that the treatment is going to be better. That's what we call therapeutic misconception. But it really does require a certain giving of patients. And in this trial, as with many trials that have been done for deep brain stimulation, patients were selected, if they were potentially good candidates for the surgery, and then randomized to a medical therapy group or to a neurostimulation group. And this color coding shows you the distribution of these patients' day on average between being mobile with troublesome dyskinesias, mobile without troublesome dyskinesias, so that's good on time, and then we have immobile or off time. What you can see is after 6 months, best medical therapy, these patients just don't get much better. Their day is the same 6 months later as it was when they started. Versus the deep brain stimulation group, you can see they have at least 4.5 more hours per day of good on time. They have decreased off time, and they have decreased time with dyskinesias. So overall, these patients are doing much better than the arm of patients that was best medical therapy. Lots of quality of life factors here as well. Activities of daily living improve, emotional well-being improves, bodily discomfort, social support, many better with deep brain stimulation compared to best medical therapy. Just a couple more notes on the surgery, and then I'm going to get into how this works, which is what we have learned about the Parkinson's disease brain. There's two different targets that we use for deep brain stimulation. There's the globus pallidus and the subthalamic nucleus. The highlight here is that they are both essentially the same when it comes to motor control. The subthalamic nucleus allows you to reduce your medications a little bit more than when we stimulate the globus pallidus, but it happens to have a little bit greater complications with respect to neuropsychological examination. So we need to balance that. That's something we take into consideration when we're considering what target to aim for with the deep brain stimulation surgery. So who's a good candidate? Based on everything that we've learned from people who've gone through clinical trials, this is for deep brain stimulation in general, but we need to confirm the diagnosis. We need to make sure that meds are effective but problematic, so there's that fluctuations. We need to make sure that the symptoms we treat interfere with quality of life, and then other things that make sure that you're ready for surgery, but that you have realistic expectations. So I don't want to say that everything is wonderful. Part of our research and part of learning has to do with going back and looking at the complications that we see with these types of surgeries. Hemorrhage or bleeding in the brain is the complication that we fear the most, or patients fear the most, but it's actually not that common. Several studies have shown that it's less than 1% chance of having a bleed that will cause a permanent deficit. Several studies have shown that. Infection is another area that we really focus on. It's actually more common, a 4 to 5% risk of infection. This is a wound with an infection in it. And we do a lot of work to try and reduce that as well. There's publications showing how to really maximize that, minimize the chance of having an infection. And then there's stimulation-related side effects that we try and control as well. And so how do we do this? Evidence, research is really important. At UCLA, what we've done is we have an evidence-based best practice guideline that has been, we've gone through all the literature and integrate everything that we know to try and reduce bad outcomes and maximize good outcomes with standardized order sets. And that's really the way that medicine has gone, is to rely on research, rely on what we've learned in order to maximize outcomes. We really emphasize that DBS is not a cure. It's not everyone's a good candidate. It's only appropriate if the tremor or the other movement symptoms are a major source of disability. It doesn't work instantly and really does require a multidisciplinary team. So, a question that we often get, and now getting more into the research side of things, is how does DBS work? How do we optimize the targeting? How do we make it more personalized? And that's really where we need more investigations, because for a long time, when I started my practice, people said, well, how does DBS work? My answer was a simple, I don't know. And what we've done is, with a lot of work, a lot of contributions from our patients, we're starting to make progress. We're starting to understand with much greater detail where the best spot is in the brain to put these electrodes. What actually happens to the brain when we turn the stimulator on, and what is wrong with the brain in patients with Parkinson's disease, and how do we target those abnormal signals in order to make patients better. So I want to tell you a little bit about our philosophy, our research approach, and what we're studying. So everyone has probably heard about Lewy bodies and the pathology that we associate with Parkinson's disease. But I'm not going to focus on that kind of pathology. I'm going to talk about brain function and how the Parkinson's disease affects brain function. And to make it a little bit more understandable, I want to tell you about the heart, because that's something we all understand a little bit better. If you have a problem with your heart and you get an arrhythmia, you get an EKG, your doctor says your heart just isn't beating the way it's supposed to beat. And then your doctor says, your cardiologist says, you need a pacemaker. There is barely a person in the world who says, well, I know the cardiologist says I need a pacemaker, but I really don't want one, so I'm not going to do it. But the whole point of a pacemaker is to make the heart beat at a more normal rhythm. And what I'm going to propose to you is that the brain is not that different. When you have a disease like Parkinson's disease, it causes the brain to have abnormal rhythms. we can record those rhythms from the brain. Just like an EEG records signals that are coming off of the brain, we can directly record those rhythms from the brain. And when someone has Parkinson's disease, you get an arrhythmia. Those rhythms change. And what we think happens with deep brain stimulation, just like a cardiac pacemaker, a brain pacemaker helps us get to a more normal pattern of rhythms in the brain and more normal function. And so that's the overview and the type of research and results that I want to show you in the subsequent slides. We also want to make sure that our research is really focused on the needs of patients. I'm a scientist. I want to understand the brain, but I'm also a doctor. I'm a physician. I care about my patients. I know, after doing this for 10 years, where our pain points are. What are the things that we want to make better about our stimulation systems? So here are some obstacles that we know or that we've recognized over the years. The symptoms that we treat are limited. We treat tremor, we treat rigidity, we treat bradykinesia, we treat dystonia and dyskinesia. We don't treat problems with gait, balance, cognitive issues. We don't treat a whole lot of symptoms that occur in Parkinson's disease. So that's the area, this is how we define the areas that we need to do research. We have imperfect targeting. If our electrode is off by just 2 millimeters, the stimulation may not work as well as it might otherwise. Our systems are not smart. We live in an era of smartphones, smart everything, smart cars. The fact that our systems are not yet smart really means that it's an impediment to dissemination. I'm in Southern California, and I have patients who drive 4 or 5 hours to come see us, but that's very difficult. That's asking a lot of patients. If we can create a system that's smart, that could detect brain signals and program itself, hey, that would make it a lot easier to help manage patients who live far away. Part of this is because we just don't really understand how deep brain stimulation works or how Parkinson's disease affects the brain, and so we need to do research to get to that point. And also we need to realize that incremental improvements may be really helpful. We don't always have to aim for perfection and a home run. Sometimes a base hit or can get us a far away. And so this is a very, very busy slide, but what I want to tell you, and I sort of alluded to it in the other slide, is that the brain is a very complex organ. You all don't need to hear that from me. You know that already. But for a long time, as we did deep brain stimulation, we thought a lot about, well, what's going on in the subthalamic nucleus or what's going on in the globus pallidus. We didn't think about how complex the brain was. And what we've realized over time is that the brain is a very complex network, that diseases like Parkinson's disease affect networks. And there are these very rich connections in the brain. And more importantly, deep brain stimulation doesn't just treat one part of the brain. When we stimulate one part of the brain, it actually has effects all over the brain. And that we know that, we can actually stimulate at multiple points and get good outcomes. We know that from doing deep brain stimulation for globus pallidus as well as subthalamic nucleus. So we know a lot of information that we should start looking more broadly. We need to understand how the brain talks to itself and how that talking to itself across these networks affects or impedes the ability of patients with Parkinson's disease to function normally. All right, so networks is really what I focus on. I really look a lot about how different parts of the brain are connected to each other or how they talk to one another. So I'm going to start with some imaging work. This is like MRIs, which everyone is probably familiar with, and tell you about where the current state of our work is in deep brain stimulation. We came from an era of indirect targeting, pneumoencephalography, big word. That's how it used to be done decades ago. We would inject air into the brain, take an X-ray, and take our best guess at where things were in the brain. We moved to an area of direct targeting where we actually get really good MRIs and we can see some structures. But even then, structures are big. Sometimes we don't know the best part of the structure to go to. And now we're moving towards network-based imaging. So can we use advanced imaging to see those networks that I was talking to you about in order to improve our function and improve our surgeries? And the reason why is because imaging doesn't show all these really complex connections that occur in and around the targets that we are aiming for. So here's some work that was originally done actually in patients with essential tremor, but it illustrates it so well that I want to share it with you. This is a typical MRI of someone's brain. And in essential tremor, we try and put the electrode in the thalamus. It's this big gray area in the brain, and there isn't much detail there. We take our best guess, a very educated guess about where to put our electrodes. But we can use some advanced algorithms to say, well, I don't know exactly where I want to be in this yellow spot, but can I figure out how this yellow part of the brain is connected to the green, red, and blue parts of the brain, and get a little bit more information about what's going on in this yellow region. And what I'm looking at is, how is each spot in the thalamus connected to other parts of the brain? And we get these heat maps. So, you know, the light blue here is more connected to the blue area here, the yellow is more connected to the reddish area here, and so on and so forth. And when we did that, we realized that we can actually use this information to know exactly where our electrodes should go. So this green spot is our electrode. It lands right in the yellow. The green ends right in the yellow. You can see consistently our electrode, we can predict with a very high level of confidence where our electrode should be. So that was great, because this led to a whole bunch of other studies, and this is just one in Parkinson's disease, showing us that in the subthalamic nucleus, which is an area that's very commonly used for deep brain stimulation of Parkinson's disease, we can do the same type of work. We can look at the connections from the subthalamic nucleus to different parts of the brain, and suddenly this area that is actually pretty small already, we can now find subregions within that area and know where to target within the subthalamic nucleus with this very advanced imaging. And so remember where I talked about the difference between awake mapping and asleep surgery. If your surgeon knows that exactly where to go based on this type of imaging, well then I'd rather have my surgeon have all of this information rather than just what we had before. And it's this advanced imaging, mapping, and how we correlate it with the patient outcomes that really helps us do that. So imaging has really taken us to the next level in order to improve the precision of our implants and get it in the right spot. So patients with essential tremor and Parkinson's disease have done a lot to help us. And just to let you know, and the reason why that sense of altruism is so important and why the impact of this research is so great, this is some work that I also do in patients with depression. So depression, deep brain stimulation for depression is not yet approved, but we took the same concepts that we learned in patients with movement disorders, with essential tremor and with Parkinson's disease. And we said, well, if we can look at how to target our electrodes based on connectivity, how the brain is connected in those diseases, can we do it for depression? And this builds upon work that was done by Helen Mayberg and her group at Emory and now at NYU, and work that we've done here to show that, yeah, we can actually predict much better where our electrode should probably be to make deep brain stimulation work for depression. Now, again, I don't want to get into too much detail about this, but to just show the impact of participating in research and how it doesn't just help you, it helps people in your disease group, patient with Parkinson's disease, but also can help us treat other people who you might not imagine. All right, now to a bit more detail about Parkinson's disease. As I said, we need to not only stimulate, but we really, to make that next leap into smart, deep brain stimulation systems, we need to be able to sense the brain. Right now, our paradigm is to do manual programming. We turn the stimulator on, and then we have intermittent assessments. Those of you who have deep brain stimulation know that you see your neurologist, you know, initially maybe every few weeks or month, but then every 3 months to 6 months. It's a very intermittent process. It's not optimized. It's time consuming. We don't really know much about the physiology, and it limits our ability to make, allow more people to take advantage of it. We want to get to a point where we detect patients' brain signals. Those signals are analyzed by your stimulator. That once you analyze it, the stimulator knows what it's supposed to do. It stimulates the brain, and then it looks at the brain and says, hey, did I do the right thing? Am I stimulating the patient in the right way in order to make their symptoms better? And this becomes an automated system and frees up the neurologist's time to take care of the other issues rather than spending time on programming. And that's our grand vision. But to do that, we need to learn a lot. We need to know, do brain signals represent how sick someone is? Do they represent the symptom severity? When we turn the deep brain stimulator on, does it actually make those signals change? Where should we record these signals from? And so this is where we've directly learned from recordings in patients with undergoing deep brain stimulation implantation. In a cartoon here, you see there's an electrode being implanted deep inside the brain, and we can listen to the brain through that electrode that we normally implant in the brain. But in addition, we put a strip of electrodes over the motor cortex, the part of the brain that controls movement. Because as I said, I'm very interested in the networks. I want to know how different parts of the brain are talking to one another. So I can record from deep inside the brain as well as from the motor cortex and see how these areas are interacting with one another. Then we do some fancy imaging work to see exactly where those electrodes are and start to do some really sophisticated and complex analyses to take a look at these signals. I just wanted to orient you all to what these signals are. Everyone has probably heard of an EEG where you see brain oscillations and brain waves. We're doing the same thing. We are listening to the brain through our electrodes. And you don't need to know what all these things are, but the brain has all these different rhythms or oscillations, and we can start to tease those apart. We know, we can know how much of a, let's say, 20 hertz oscillation there is, or how much of a 30 hertz oscillation. We can do some very complex analyses, but the easiest way to look at this is, here's an electrode that we're slowly advancing deep into the brain, and you can see the deeper we go, anyone can plainly see that this signal here looks a little bit lighter blue here versus out here, looks a little redder down here than it does look out here. Those are the signals that we're looking at. We are looking at our target engagement. As we advance our electrode, when we get to our target, we can tell that we're there because it has a certain profile. We can also look at these oscillations that are color-coded here, and we can see movement. So here is a signal from recording on top of the brain, the motor cortex. You can see when patients move, that red goes away, becomes yellow, then it becomes red because they stop moving. And you can see them resting, moving, resting, and moving, and the same thing deep inside the brain. So what I'm hoping to convince you of here is that we can record and tell when someone is moving and not moving. That's a really important point, right? We know that we're at target because it has a certain profile, and we can actually detect movements. So this sets up our platform to really start to study the brain. And as I said, I'm a believer that the brain has these oscillations just like the heart has rhythms, and we need to understand these oscillations as part of Parkinson's disease, and that's what I hope to convince you of in the next several slides. All right, so you saw some of these before, these types of graphs in the last slide, and I'll talk you through these. These are some interesting findings just to get you warmed up to this concept. But these are some basic experiments we did in the operating room where we ask patients to move their hand, open and close their hand when we tell them to. So it's what we call an externally cued hand movement. I tell them, move your hand or rest. And this is in patients with Parkinson's disease. This is patients with essential tremor. And you can see the Parkinson's disease patients don't change their brain signals as much. They have a tougher time activating the brain when they're told to move. But overall, it occurs around the same time, especially this blue area. And the red area here occurs around the same time as well. So Parkinson's disease don't activate the brain quite as much. They're not able to recruit the brain as well as they want, but it occurs around the same time, just not as powerfully. Now here's a really interesting finding on our next slide. This is different. This is where we tell the patients, hey, move your hand whenever you want. I'm not going to tell you when to do it. I'm not going to tell you to move it, but move it whenever you want. And again, you can see in Parkinson's disease, the blue area is not as blue as in essential tremor. But you also notice in Parkinson's disease, people are becoming, this blue occurs a lot earlier than essential tremor. And a lot of you might be thinking, well, that's how I feel as a Parkinson's patient. When I want to start moving, I have a tougher time starting. So your brain is starting to move before you actually move. The dotted line represents where movement actually occurs. You can see there's up to 1 second of changes in the brain before the patients actually move, whereas in essential tremor, it's just 100 milliseconds beforehand. The red actually corresponds with actual movement, so you can see when the actual movement occurs. But this is really interesting. This is actually a physiological basis for what Parkinson's patients experience. It's harder to move, and it's harder to start movement. It's not that your brain isn't trying. It's trying. We can see that it's trying. It just takes a little bit more to get you over that threshold. All right, so this is some insights into what's happening in the brain in Parkinson's disease. So now I've shown you that we can record these signals. We can tell when patients are trying to move, when they're actually moving. Now I want to get into that network theory that I told you about. And this slide is purposefully confusing because it's so complex. But there are, there's the motor cortex is one part of the brain. There's the globus pallidus, the subthalamic nucleus. There's all these different parts of the brain that are talking to one another, trying to make the body move. Beta is a certain type of brain rhythm that we're very interested in Parkinson's disease. It's been studied in the motor cortex. It's been studied in the subthalamic nucleus. It's been studied in the globus pallidus. And we took a step back and said, well, if it's in all these different places, how are they related to one another? And we thought, well, it might be that the problem is that all these areas are talking at the same time. If they are all expressing this beta, they all have this beta oscillation, it's like a group of people all saying the same thing at the same time and nobody being able to communicate. And that's what our working theory is for what's happening in Parkinson's disease. The brain is too synchronized. Everything is firing at the same time. And if everything's firing at the same time, you can't get a message through. That's probably why the brain starts trying to move but can't actually move, because the signals can't get through it. So here's some data to support this. And again, very complicated, and I don't want to go through all the signals, but I'm going to overall show you what we see here. So in this case, I've put a cartoon here. You can see this red box shows you where we're recording from, which is the globus pallidus. And in this case, we look at patients recording from the globus pallidus at rest and with movement. And we wanted to know, is there something about these signals in the globus pallidus that tells us about how severe a patient's symptoms are? And we look at a very special kind of oscillation, which is what we call phase amplitude coupling. And again, I don't think you need to know that, but know that we're looking at those rhythms that I talked to you about. And look at these lines. So here's a hemibody UPDRS. That's UPDRS is our standard rating scale for Parkinson's disease, and you can see that there's a very strong correlation between this phase amplitude coupling, or these oscillations, and how severe people's symptoms are. Likewise, there's and we've got many different measures like this that show, hemibody UPDRS or rigidity and bradykinesia. We have a lot of signals that we can look at instantaneously in a patient's brain and know how severe their symptoms are. So that's great. Remember, I said we need to know if we have signals that can tell us about how sick someone's brain is or how severe their symptoms are, because without that biomarker, we're not going to know when for a smart deep brain stimulation system to work. So it turns out these Parkinson's patients do not have normal oscillations that we see in patients with less severe symptoms or no symptoms. We said, well, if we can see that in the globus pallidus, why don't we look up at the cortex? So again, this is a cartoon to show you where we're recording from. And sure enough, we see the same thing again. We look at this phase amplitude coupling, and again, there's a strong correlation. The more severe someone's symptoms are, the more significant coupling they have in their motor cortex. So this was, one of the most important things we need to show is that we know that Parkinson's disease patients have disease in their brain, but do they have signals or oscillations that can tell us what's going on, how severe their symptoms are? And the answer is yes. We can see it both in the globus pallidus as well as in the motor cortex, or at the top of the brain. So next part is, remember I said, not only do we need those biomarkers, we need to, we now know that the oscillations, those rhythms are not normal or in patients with Parkinson's disease. What happens with deep brain stimulation? And so, again, looking down at the globus pallidus in this area, we can see with deep brain stimulation, we actually are able to drop this beta signal in the globus pallidus. So therapeutic stimulation decreases that abnormal beta oscillation in the globus pallidus, which is very good to know. And if we look up at the cortex again, we're looking for biomarkers that tell us that stimulation is working. Remember, there's this abnormal coupling here. When we turn the stimulator on, that coupling goes away. And in fact, if we look at how much that abnormal coupling goes down with stimulation, so this is stimulation changes in that phase amplitude coupling, it corresponds with improvements in bradykinesia. And just to emphasize again, the reason why this is important is now we have a biomarker that we can say, hey, when we stimulate, people get better, and we know that the brain signals change. So now you should start thinking, well, this means if we design a system that can record these, we can send people home and let the machine figure itself out. And machines will be smart enough to do this in the near future. The similar work was done at another group. I'm not the only one who does research like this. This is from Phil Starr's group at UCSF, showing that that abnormal coupling goes away with stimulation, and then it comes back when the stimulation turns off. In their case, they use subthalamic nucleus stimulation. And we looked at one other factor, which is this coherence, that idea that two areas are oscillating at the same rate. So imagine this is one part of the brain and its signal, and this is another part of the brain and its signal. And if they are talking at the same time, it's hard to hear anything. We know that there is coherence, or that this occurs between different parts of the brain, as you can see here. For the sake of time, I'm not going to talk about that one little figure, but I will show this, which is that if we record from the cortex as well as from the deep brain, when we turn the stimulator on, the signals go down. So we have this abnormal coupling where the two parts of the brain are talking at the same time. We turn the stimulator on, and suddenly they're not talking at the same time, and signals, we know patients get better and they're able to function better. So this is really interesting stuff. We're learning about how Parkinson's disease affects the brain, but we're also learning about how deep brain stimulation improves brain function in patients with Parkinson's disease, which, 10 years ago when I started, I did not know these answers. I want to show a couple more things, then we'll open it up for questions. You might be saying, well, this is all great. How does this actually work? Is it actually relevant? This is work from Phil Starr's group at UCSF again, and they used a closed loop system. So Medtronic has a device called a PC plus S, which means it's a brain stimulator that can sense, and they were able to show that you can see certain signals related to dyskinesia, and they designed the system that actually responds to dyskinesias and turns itself off if it sees dyskinesia signals, so on and so forth. And what they are able to show is that with their system, patients do just as well, but the stimulators, you save about 40% of the stimulator energy. And for those of you with a deep brain stimulator that you've needed battery replacement, you can imagine if you can have your battery on for 40% less time, that means you're replacing your battery less often, and it's a huge advantage for patients. So even if we're not doing better, if we're doing just as well but saving battery, that's a huge advantage. And this is an intriguing study from Peter Brown's group. So there's a big group at Oxford that looked at no stimulation, continuous stimulation, and ADBS is adaptive deep brain stimulation. And they said, this is in a very controlled setting, but they thought that with their adaptive deep brain stimulation, so looking at these brain signals that we're talking about, patients might do even better than with the continuous DBS, which is what we currently use. So some intriguing early data that's really driving a lot of this research. One last nod, remember I said there's one group of studies that we do that actually don't even directly reflect on Parkinson's disease, although it is relevant to Parkinson's disease. But we do some studies to look at how the brain handles conflict. And we know the subthalamic nucleus is involved there. Just to show you, we're trying to understand how the brain deals with conflict, how it deals with motor control, independent of Parkinson's disease. I'll just highlight one thing here, which is to show that there's a certain signal here that seems to highlight when a patient is dealing with a conflicting situation. Really interesting, because we know that patients with Parkinson's disease don't deal with conflict terribly well. This, again, this type of research where we're recording from patients' brains from deep within the subthalamic nucleus, it doesn't tell us anything about how to manage the patient, but learning this stuff will help other people in the future and help us as a society understand how our brain functions and helps us survive. This is another scenario where we're looking at how the brain controls stopping. So that classic scenario where you might be trying to cross the street and suddenly a car comes by, you got to stop yourself from crossing the street. We're able to record during surgery and see what parts of the brain are responsible for that stopping. This is a different part of the brain, which is the right inferior frontal gyrus, but a huge stopping signal to tell us how the brain is controlling that. And actually, Parkinson's disease patients have some impairment with that type of stopping as well. So, really exciting stuff that we've learned. And I'll say it again, we could not do it without patients who have volunteered to do this. And I can confidently say in the 10 years that I've been in practice and doing research, I've gone from saying, I have no idea how deep brain stimulation works, and I don't know exactly what Parkinson's disease does to the brain, to really having a much better picture of what happens in patients with Parkinson's disease, how the brain is affected, and how deep brain stimulation is addressing those symptoms. This is a whole lot of detail that I put here. It'll be on the video. You can pause it and look at it later, but it summarizes a lot of things I talked about. But I think the summary I just gave you is the most important part, which is that we have Parkinson's disease patients have these abnormal rhythms, and deep brain stimulation is able to directly target those rhythms, make them a little bit more normal. And when we make them more normal, that's when the symptoms get better. I think we've got a wonderful field in deep brain stimulation. It's an extremely effective therapy. It's obviously not great for everyone, but we have a lot of improvements we can make. I listed all those obstacles for you. I do think that we really need to think about the brain as a network. And when we look at it as a network and how these oscillations and rhythms propagate through that network, we're really going to make huge advances in terms of improving our therapies for our patients. I should say a lot of these signals are directly relevant to medical therapies as well as deep brain stimulation as well. Want to end again with a big thank you to all of the patients who have volunteered for this, as well as acknowledge the really important role of these altruistic participation, that we're all one team, and the funding agencies like the NIH and the Brain Initiative in particular that have helped us make huge progress in this area. I've got a huge team of collaborators and researchers who have helped us get to where we are, and they're acknowledged here. And that's our clinical team. Myself and Dr. Bordelon lead this on the neurosurgery and neurology side respectively, and we've got another neurosurgeon and an additional neurologist as well working with us. And a final plug, if you are close to Los Angeles, and we do studies outside of the operating room as well. If you're interested in participating in research to help us understand more about Parkinson's disease, there's some information here and some contact information that you can call us. So on that note, I am going to take a break from talking and invite questions.
Okay, and I have some queued up. So there are quite a few questions about when, how soon, I want it now. Obviously, that's not an easy answer, but if you had to maybe give us a timeline, when can we start to see, for example, some of the smart technology?
So the smart technology that has been used to date is all research-based technology. So the only company, I think it's worth giving them a nod, is Medtronic, who has any device that can currently do sensing, which is what we're talking about now. And they are actively working on creating a device that will be commercially available. I don't know the timeline. I think it's going to be on the order of a couple years, is my best guess. That's what they say, but it might take a little bit more time. But one thing I will point out, all of that technology is what goes in the chest. What goes in the brain is exactly the same thing. So it's very, if I wouldn't delay if you're a candidate for surgery and you would benefit from surgery, you shouldn't delay getting the surgery, because you can always get your generator replaced to upgraded technology that's closed loop if it's appropriate for you to have that. But I would guess it's going to be on a 2 to 4 year time frame where we start seeing that in the mainstream.
That's a great point, not to wait. Okay. Does your research explain or shed any light on some of the personality changes that can happen after DBS implantation?
So that's great. I went over that very quickly at the end for the sake of time. But some of the personality changes, one of the most common ones we see is decreased inhibition, or the impulsivity that can occur with deep brain stimulation of the subthalamic nucleus. And that was, if I can go back on my slides, let me see if I can. This is why we are doing this work, this ability to deal with conflict. We know that patients with deep brain stimulation do not deal with conflict as well. They make decisions more quickly and more impulsively. And although I said this is really neuroscience work, it does have implications for patients with Parkinson's disease. And what the data is too early for us to do, but we are focused on trying to understand the role of the subthalamic nucleus in this conflict processing, how stimulation affects that conflict processing, and how we can do two things. One is know where that conflict processing is occurring in the subthalamic nucleus so that we're not stimulating that area, but also looking at the signals in the subthalamic nucleus so we can say, okay, well, this area seems to be doing this. We're going to use these biosignals to drive us away from disrupting that normal function that the subthalamic nucleus is responsible for. So yes, we're trying to look at that, but whoever asked that question is a little bit ahead of their time and predicted what we're already working on. We just don't have the results yet.
Very good. I'll read this one verbatim. Is EEG biofeedback targeting the abnormal beta rhythms at the cortex a suitable technique for people with Parkinson's that don't qualify for DBS?
So my short answer is I don't know. I think it's very intriguing. I don't know if this abnormal beta that we see can be modulated or controlled by biofeedback. I think that type of work is experimental and it's investigational. I think there's very little downside to participating in trials, and I encourage people to participate in trials so we can learn from it. Perhaps I should highlight, I think it's important to participate in trials, not to just do it with the expectation that it's going to work, but we need to learn more about it. My gut feeling is that this beta, as I said, it's going throughout the entire brain. It's not something we can control. It's something that sort of needs to be knocked down either with medications or with stimulation. If we can find a way to control with biofeedback, that would be great, but I just don't think the data is quite there yet.
Okay. And from your research, do you think it's ever too early for tremor-dominant PD patients to get DBS?
So the timing of when you have surgery has to do with a few factors. The important parts are making sure that you've had an adequate medication trial. Tremor-dominant Parkinson's disease it's well recognized that the tremor may not respond to medications. Sometimes those are some of our earliest patients to go into deep brain stimulation therapy. But the other thing is when the tremor becomes disruptive. So, we have some young patients who have tremor who are trying to function at a high level. And we also, I shouldn't discriminate based on age, we have some older patients who are very functional but have tremor, and that's impairing their ability to work or do other things that they're interested in. That's the threat when it's causing functional impairment that you should go into surgery, or you should consider surgery at that point. So I don't think there's a time that's too early as long as certain diagnostic criteria are met.
Okay. I've read an article that DBS might be used to treat obesity. Is that one of the additional, I guess the question is that along with depression, is that something that's going to be on the cutting edge of a way to use DBS?
I think so. So we have gone through an era. Can I go to video instead of having a...
Uh-huh.
That I...
Great.
You can see me. We went through a period up until about 3-4 years ago where, you know, deep brain stimulation works so well for Parkinson's disease that everyone felt like, well, then I'm going to treat obesity, I'm going to treat depression, I'm going to treat all these other diseases just by putting an electrode in someone's brain. So we've had a lot of trials of deep brain stimulation for obesity, depression, obsessive compulsive disorder. And unfortunately, not many of these trials have come out positive, meaning that they've had a positive impact on patients' quality of life and function. Now, what we're doing is people are really looking at treating these other diseases, diagnoses. As I said, we have some work being done in chronic pain and depression, but we're all taking a very different tack than we had before. Now we're, like I showed you now, like we're doing for Parkinson's disease, we've learned a lot from what we've done in Parkinson's disease. Said, well, we need to do the same thing in other diseases, because if we can learn about patients' brain who have obesity or depression the same way that we've learned about Parkinson's disease, then we can probably make the deep brain stimulation therapy work for them better than just, you know, a shot in the dark and putting an electrode in the brain. So yes, I think there's a lot of, to get back to the original question, there is a lot of hope that we can do things for obesity. Obesity is an interesting diagnosis because a lot of people think that it's a non-neurological disease, but I would argue that overeating, impulse control probably does have an origin in the brain. I am hopeful that one day for people who are obese, who have control issues, the deep brain stimulation may be an effective therapy. I think it'll be a small number of patients, but may be effective.
Okay. And then this might be the last. Okay, 2 more questions. Jim says he already has DBS. Is he still a candidate to participate in research?
Yes, not particularly this. We won't take you back to the operating room to do it, but yes, there are. We have a lot of trials at UCLA and other centers. You know, we have studies where we do functional MRI with people who have deep brain stimulators implanted. We do behavioral studies. We do EEG studies. We have gait studies. We have many, many different studies. So there's barely a patient with Parkinson's disease we don't have a study that they would qualify for. So if you're interested and want to give back in some way, we welcome that.
Okay, very good. Kimberly asks, how do we know whether the DBS stimulation pattern we're using is optimal?
It's a fantastic question, and the short answer is we don't, and that's part of what we do. So we know, generally speaking, that I'm going to give this in 2 different answers. So the most common question is, what frequency should we be stimulating at? And we know that we do high frequency stimulation for Parkinson's disease. We don't know which of those high frequencies is the best one. We do know that low frequency stimulation seems to be ineffective. So we're doing a study, we're almost done with it, looking at, you know, these brain signals that I showed you, what changes with low frequency versus high frequency to let us understand which of these brain signals are actually relevant. But something we need to do is really sweep the entire frequency range and say, you know, how do these brain signals respond to all these different frequencies? How do we optimize the frequency of stimulation? The other question, which you may not have meant, but I think is really interesting, is we do a fixed pattern of stimulation, meaning we stimulate at a very fixed frequency, 130 hertz or 160 or 185 hertz, which means every second you stimulate the brain 185 times evenly spaced apart. We have absolutely no idea that that is the best pattern of stimulation. It might be that we should be randomly stimulating the brain in a random order of random frequencies. We just don't know, and that's part of the research that we need to do to get to a greater understanding of how stimulation works and which patterns are best. But that's, you're looking ahead of where we are now, and that's fantastic.
Okay, very good. Well, I think that is all of the questions, and we're right at 1 hour. So again, thank you so much. That was, the comments are coming in that was a brilliant presentation. Thank you for trusting the audience that we can handle a high level. You know, PD 101 is great, but sometimes this is such a complex disease, and you know, the people that I meet, they are so hungry for knowledge and spend a lot of their time and energy, researching and understanding. So thank you for being willing to share at this level with our audience. Again, everyone, because you might want to watch this again, it will be on our website, and we'll send out, if you're not subscribed to our email newsletter, do so. Follow us on Facebook so we can communicate this out to you. And then there's a lot of those slides, Dr. Pouratian, like you mentioned, you can pause and get information on how to reach out to UCLA to participate in some of this research, or to become a patient, or just to follow up with everything that we covered today. So thank you everyone for sharing your attention and your energy, and thank you again, Dr. Pouratian, and thank you, our overall sponsor, Medtronic, helped make this program possible. So have a great day, everyone. Thank you so much.
Thank you.